Good morning, everybody, and welcome to our first grand rounds of this academic year, which is a special hospital-wide grand rounds, not just for the Department of Medicine. And it's really a very special grand rounds to update people and to make sure everybody's very familiar with all of the new COVID-19 guidelines in terms of the vaccine mandate. Now, this has been a difficult year. That's I think, a very mild way to put it. But hopefully it's a year that we are beginning to start seeing optimism with the vaccine. And that's what I want to talk about today. The new vaccine mandate that the government came out with in New York, as well on a national basis. Some of this vaccine mandate is also applicable on a national basis to nursing homes. But for New York State, it applies to hospitals as well. And last week, there was a meeting of the New York State Public Health and Health Planning Council, which oversees such regulations, and they have mandated. That means it's obligatory for every single person working in healthcare and hospitals. It will probably be rolled out in the near future to people working in healthcare anywhere. But this is for healthcare workers working in hospitals and nursing homes at the present time, are mandated to have vaccination for COVID-19 with any of the three vaccines that are approved for this, either through emergency use authorization or now FDA approval for the for the Pfizer mRNA vaccine. So it's now mandated that all healthcare workers, that includes voluntary medical staff listening to this grand rounds, all employees of the hospital are mandated to go and get vaccinated. If you've been already vaccinated, obviously not a problem. If you haven't been vaccinated, this will have huge consequences for you. So again, it's not an option. Hospitals can't opt out. Hospitals must have all of their employees fully vaccinated. And originally, the governor had allowed a religious exemption. A person who has strong religious feelings would have been entitled to apply for an exemption. It wouldn't be guaranteed that just because you say you have a religious concern about the vaccine that you would get it. There was a whole process that Mount Sinai had put into place, as well as all other hospitals across the state had put into place. But the Public Health and Health Planning Council removed that religious exemption. It's not Mount Sinai South Nassau that did that. And no facility in New York is going to be able to give out any religious exemptions. And even if you had been granted a religious exemption previously, you would not be able to use that religious exemption. It's null and void. And this mandate that the state has put out requires that every healthcare worker in the hospital or in a nursing home have gotten at least the first dose by September 27th. We strongly would urge everyone to get both doses by then. It's not too late. You can still get vaccinated today if you haven't been vaccinated and have both doses in time by then. Now, everybody has to understand that this is a horrible disease. If you've worked in the hospital, if you've been with us on our worst day when we had 405 COVID patients in the house, most of them requiring ICU level of care, if you've seen the horrific damage this illness does to people, even if they do survive it, the long COVID effects, the difficulties that people have while they have this illness that can stretch beyond the illness, the acute phase of the illness. This is not an illness that anybody would want to have. And even people with mild illness are subject to long-term complications that we really don't fully understand at this point of time. And the only way out of this crisis is vaccination. We do not have great therapies for this. There's still many things that are being looked at. There are many things that are being tried, but we do not have real therapies that can take care of this illness if you get it. Monoclonal antibodies are great. There are some other new therapies coming down the pike that will hopefully be very helpful. But you do not want to rely upon monoclonal antibodies to get you out of trouble. And they'll only work for an individual person one time and hopefully have benefit. Vaccination is the way out of this crisis. Now, are there any exceptions to this mandate from the state? So yes, there are for very, very specific medical conditions, potentially a medical exemption. These are people that I would say should not get the vaccine, even if there was zero concerns about the vaccine, even if the person wanted to get the vaccine, there are certain people that the vaccine for them would be dangerous. This is very, very, very rare that this would apply. This is essentially for people that have had an extremely bad reaction, for example, to the first vaccine that they got. And now they're talking about their second dose. They had an anaphylactic reaction to their first vaccine. So these are the people that we would consider only under very specific situations to give a second dose. Similarly, if you had an injectable treatment with a similar type of product and you had an anaphylactic reaction. But most medical conditions are a reason to get the vaccine, not a reason not to get the vaccine. We have a committee at the Mount Sinai system level. I'm on that committee that looks at employees that have submitted for a medical exemption. And we do grant those when they're appropriate. Most of these people need to be seen by an allergy immunology specialist and to work with that physician specialist to see if there is a way still to get the vaccine if they've had a very, very bad allergic reaction. But these are very narrow criteria. And anybody that does get an exemption will have to undergo at least weekly PCR testing to make sure that they're safe for their friends, their family, the Mount Sinai family, and for their patients. Now, HR will be coming out with some announcements. This is not an HR talk, but HR will be coming out with the specifics of this, how this may apply to any individual if they are in the process of getting vaccinated, haven't yet done so, or if they are not getting vaccinated, there will be consequences, but I'll leave that for the HR people, our wonderful HR staff to address. What does this mean? So I'm going to go through the following 6 points and try to leave time for questions at the end. We have a lot of physicians on this talk from the medical staff, but we also have a lot of nurses and a lot of other employees in the hospital. So I will try to make this a talk that not only people with a very strong medical background can understand. I won't go into as much detail on some things, but I'll be happy to take questions afterwards. And certainly if any of the physicians, if I don't go into enough sufficient detail for them, please call me up and I'll be happy to go through anything in more detail. So I'll go through each of these specific types of issues and then take questions. So there are different types of COVID-19 vaccines. There are 3 that are approved in the United States, as everybody knows, the 2 mRNA vaccines, the Pfizer, BioNTech, and the Moderna. They work with a certain type of technology, which we now have 4 billion doses of experience with. So people who are concerned originally, I don't want to be a guinea pig. Oh, I don't want to take this vaccine because it's new. Well, there are 4 billion doses of these mRNA vaccines and other vaccines that have now been prescribed worldwide. So this is no longer a novel, unusual, we don't have experience type of vaccine. In the United States, there's also licensed for emergency use authorization, the J&J single dose vaccine. The 2 mRNA vaccines are 2 doses. The J&J is a single dose. Whether you will need additional doses of either of these 3 vaccines remains to be seen, and I'll discuss that towards the end of the talk as well. In addition, across the world, there are other vaccines that are licensed, and those vaccines are also, to different degrees, very effective. But I'll focus really on the 3 vaccines that we have in the United States. So how good are these vaccines? What is their efficacy? There's a lot of talk with Delta that maybe they're not so good, and you read in the newspapers that the efficacy has gone down from 90% to 80%, 60%, 40%. So let me tell you, we don't practice medicine by what's published in the newspapers, and that it's critically important for people that are experts in the field to assess the data and to provide their expert opinion. So what is that expert opinion? So if you look in August 18th, 2021, Morbidity and Mortality Weekly Report, which is the gold standard, really, public health publication from the CDC. So this is brand new and recent. And this is New York data. So for those people that say, well, it doesn't apply to us, this is our data here in New York during the month of May and June and July. So this is Delta variant data. This is dealing with what we're seeing in our hospitals, both at Mount Sinai South Nassau and across the region. And look how effective these vaccines remain against both new cases and, much more importantly, against new hospitalizations. And if you look at over time, you go down each week by week, doesn't change that much. Don't get too caught up if one week is a little bit lower or higher than the other. The main point is that fully vaccinated people are going to get COVID at a far, far lower rate than unvaccinated people. Unvaccinated people get lots of COVID. Vaccinated people do not. Now, that's just even mild, even asymptomatic cases. Let's look at hospitalizations. That represents more serious illness. Hospitalizations, if you're fully vaccinated, you're extremely unlikely, even if you get COVID, to need hospitalization. Look at that difference. That's a huge difference between the unvaccinated getting hospitalized versus the vaccinated getting hospitalized. And even if you get hospitalized, the likelihood of having a serious complication, such as needing to be in the ICU, heaven forbid getting intubated, and heaven forbid dying, are far, far lower if you're fully vaccinated than if you're unvaccinated. Those are the facts. This is our data. You're talking about a huge database, lots and lots of people. And these numbers hold true. And notice, not much of a change in terms of the prevention of hospitalization from beginning to the end of May, June, and July. So this is Delta data. And the vaccines remain unbelievably great in preventing serious illness. And that's what we're mostly concerned about. Yes, there are going to be some breakthroughs, and I'll talk a little bit more about that in a moment. But breakthroughs with mild disease or even asymptomatic, you're tested for whatever the reason. You went on a plane, you had to get tested. You got tested for some other reason. You were exposed and you got tested. So even if you turn positive, you're probably not going to get sick. That's amazing. Just amazing. Bottom line, they remain unbelievably effective against Delta and other variants that are circulating now in the United States. They significantly reduce hospitalization and death. That's the mark of the efficacy of a vaccine. Did you get through the illness it was designed to get you through, even if you got mild illness? And therefore, the best way to stop COVID-19, to stop the Delta or other variants, is to get vaccinated. And that's the rationale behind the New York State mandate to have all healthcare workers vaccinated. Yes, there will be some breakthrough infections. And yes, when you do break through, even if you're vaccinated, you have a risk of transmitting it to others. The data suggests that vaccinated people who get COVID have the same viral levels as unvaccinated people who get COVID. So if you do get it, you are contagious. And that's important to remember as well. And that's why even vaccinated people need to be careful if they've been exposed to somebody. They don't need to quarantine. That's another great benefit of vaccination. If you're exposed, you don't need to quarantine if you're vaccinated. You do need to quarantine if you're not vaccinated. But even vaccinated people should be very careful in the period of time after an exposure. So you had dinner with friends, and it turns out that somebody there was positive. Well, if you're vaccinated, you don't need to be in quarantine, but you do need to be very careful about masking when you're around other people. You do need to get a PCR test at day 3 to 5 after the exposure, and you should be self-assessing twice daily for any symptoms, cold symptoms, loss of taste, loss of smell, etc., any symptoms during that next 14-day period of time, and then get tested again if you get symptoms. Okay, so the vaccines are great in terms of efficacy, but are they safe? How safe are these vaccines? And in a moment, we'll talk about in selected subpopulations. But let's talk in general now about the safety of these vaccines. So they're safe enough that on August 23rd, the FDA said we no longer need to use for Pfizer the emergency use authorization, but we now have enough data, safety, to say that for people 16 and older, the Pfizer BioNTech mRNA vaccine is now fully FDA approved. And that has led, in surveys that have been done, for many people who were previously vaccine hesitant, and they were saying, well, I don't want to take this vaccine until it gets full FDA approval, that has now allowed many people who are hesitant to say, okay, now I'm going to come forward and take the vaccine, even nothing to do with the vaccine mandate for healthcare workers, but people who were concerned about this. Now, I personally wasn't concerned about this. I don't think there was a reason to be concerned. The difference between emergency use authorization and FDA approval, in my humble opinion, doesn't really mean that much. But for those people that wanted that full FDA approval, it's now there for the Pfizer vaccine for people 16 and up. Moderna has applied for the same thing. There's no reason to think they're not going to get it in the very near future. J&J will be applying for the same thing. There's no reason to think they won't get it in the near future. But for now, the Pfizer-BioNTech mRNA vaccine has full FDA approval. And the FDA has stated, and there's a ton of data behind this, the public can be very confident that this vaccine meets the high standards for safety, effectiveness, and quality that the FDA normally demands of a product. So this is critically important for everybody to know. Can you please put yourself on mute? Somebody, can you please put yourself on mute? Thank you. Okay. Now, there are side effects with this vaccine. I don't mean to suggest that it's a piece of cake to take the vaccine. You do get common, local, mild side effects. A lot of people get some arm soreness at the site. They can get some swelling. A lot of people feel tired. People get headaches, get a flu-like syndrome. Invariably, they're very mild and they go away quickly in the vast, vast, vast majority of people. And again, we have billions of doses of experience with these vaccines. There are some serious side effects that people need to be aware of. In the opinion of all the experts, not enough of a concern in any way not to take the vaccines, but people should be aware of these concerns. So anaphylaxis, that's that very serious allergic reaction, occurs in about 5 out of 1 million people who are 12 years and older. The Pfizer-BioNTech is approved for 12 years of age and up, who are given an mRNA vaccine. That's compared to flu, where the data is about 1 in 2 for 1 million. So it's a little bit more. But when you think about these numbers, they're very, very, very small. And in addition, they're treatable. If you're in a situation where you have this type of reaction, an EpiPen, other emergency maneuvers can easily handle such reactions. Nobody wants to get such a reaction, but people don't die or get serious long-term consequences from these rare reactions. And only people who've had a prior injectable anaphylaxis reaction, they got injected with a medication or a vaccine and had anaphylaxis, those people should be seeing an allergy immunologist, a specialist, to see what they can do and under what situations they can take the mRNA vaccines or to take the J&J vaccine. There's a lot of talk about myocarditis and myopericarditis resulting from the mRNA vaccines. I want to give you an idea how rare this is still. 742 cases, okay, have been described. So it's not a large amount. There are more cases under investigation, another couple of hundred. I want to stress, not one resulted in death. And almost all of the cases were self-limited. Some of them are still new, so I can't say all are self-limited. But almost all of the cases are self-limited, means they go away on their own. And this is the real important thing. This occurs mostly as a second dose in young men, especially under the age of 30. But in that age group, if you get COVID, you're 6 times more likely to get that same illness than from the vaccine getting it. So for people to say, oh, I don't want to take the vaccine because I'm afraid of getting myocarditis, what you're basically saying is, I'm going to take a 6 times more likely chance that if I get COVID, I'll get myocarditis. And COVID is spreading, especially in the people under 30, because they're not as highly vaccinated as the groups above the age of 30. So this is an important fact for people to be aware of. And yes, there are some other very, very rare serious side effects, some what we call demyelinating illnesses, like a Guillain-Barré syndrome, but they're very, very, very rare. And in the overall risk-benefit the likelihood of you getting one of these reactions versus getting a real serious complication from COVID, the overwhelming likelihood is that COVID is going to hurt you, not the vaccine. So these vaccines are safe. That's for the general population. What about in specific subpopulations? Everybody's very concerned. In the healthcare worker population, there are a lot of young women, a lot of women that potentially want to get pregnant, are nursing. What about those women? Are they at greater risk? And let's be fair. What about men? Does this affect the fertility of men? So why should you want to get vaccinated if you're a pregnant woman? So this is a brand new study last week from JAMA, a large study, retrospective cohort study, looking at almost 1 million healthy women versus almost 20,000 women who had COVID. And they looked at them. They gave birth. And what happened to these women? Again, 20,000, almost 20,000 women who had COVID versus almost 1 million women who didn't have COVID. A large study. How did they do? Well, this is the most important sentence that you need to know if you're a pregnant woman. Women who are pregnant, who had COVID, did poorly compared to women who were pregnant who did not have COVID. If you have COVID during your pregnancy, you're more likely to be admitted to the ICU. You're more likely to be intubated, have a tube put down you to breathe, and heaven forbid, you're more likely to die. Pregnant women with COVID are much more at risk than a pregnant woman who has a regular, normal pregnancy. You're 5.8 more times more likely to be admitted to the ICU. You're 14.3 times more likely to be intubated. And you are 15 times more likely to die in the hospital if you're a pregnant woman with COVID than if you're a pregnant woman that doesn't have COVID. Can I ask everybody to please mute themselves?
So hospital-acquired pressure injuries, we have
Can
none.
I ask everybody to please mute themselves?
Collapsing, workplace.
Can everybody please mute themselves? Thank you. Okay. Now, you're also at significantly higher risk for a preterm birth, meaning you're going to give birth prematurely. Now, this is for pregnant women. This underscores why they, especially pregnant women, should want to get vaccinated, because this study will prevent you from getting COVID. Well, okay, I know it will work and it will prevent me from getting COVID in pregnancy, but will the vaccine hurt me if I'm pregnant? So we now have a ton of data and published papers in the New England Journal of Medicine that clearly show there is no increase in miscarriage or any adverse effect on the pregnancy in women who got COVID vaccination during the pregnancy. No increase. So you have tremendous benefit and no harm. And the CDC recently released all of their data on pregnancy from 3 of their safety monitoring systems. And again, the data did not find any concerns in pregnancy if you got vaccinated during the pregnancy for both mommy or for the baby. I don't want to do anything to my baby. Of course, we know that. Nobody wants to do anything to hurt the baby inside mommy. But that's all the more reason why you should get vaccinated, so you'll have a better likelihood of delivering a healthy baby. So this is critically important. Now, who believes this besides Aaron Glatt? So the American College of Obstetrics and Gynecology, the Society for Maternal and Fetal Medicine, the Society for Reproductive Medicine, the American College of Physicians, in addition to the CDC, all believe this data. And therefore, they have gone from a neutral statement saying it's okay to take it in pregnancy to now all of these societies strongly recommending that pregnant women take the vaccine if they haven't been vaccinated beforehand. So I hope that clears up any concerns that people might have in terms of pregnancy. Okay, what about if you're nursing, a nursing mommy, a lactating mommy? So let me tell you that the breast milk has been shown to have antibodies against COVID in the breast milk. And it theoretically, I don't have a lot of data, but it theoretically could protect your baby from getting COVID. So that's an additional nice benefit to know that if you're getting the vaccine and you're nursing, it's going to have potential benefit for your baby. Now, we don't know that for certain, but it certainly isn't going to hurt the baby. And we do know that it doesn't cause infection or side effects in the lactating women, the nursing mommies, or in their babies. So again, a nursing mother should have zero concerns about getting vaccinated if she hasn't been vaccinated yet. She hopefully was vaccinated, and she shouldn't have any concerns that it's going to harm her baby. If anything, it may help her baby. And then the final question that we get asked about with women all the time is, I'm trying to get pregnant, or I'm a young lady, I want to get pregnant in the future. I don't want to take this vaccine because there's garbage going around on the internet. I'm sorry, there is information going around on social media and the internet that says that women are going to become infertile from taking this vaccine. So that's absolute garbage. Not one study, not one piece of hard evidence to suggest that that's true. There is zero, no evidence that the COVID-19 vaccines cause infertility in men or in women. Now, there is evidence that COVID can cause infertility in men and women, but no evidence that COVID vaccination causes infertility in men or women. There is zero, no evidence. This is what the internet says. If you have antibodies to COVID, it's going to cause your placenta to be rejected and you're going to have abortions and miscarriages spontaneously. Not true. There just is not true, because some influencer on social media who has no medical training, no medical knowledge, but is either pretty or popular, says that this is true. That doesn't make it true. And there is zero evidence that the COVID-19 antibodies that are created from vaccination or from regular COVID infection in any way will interfere with a woman becoming pregnant now or in the future. So you're a young nurse, you're a young healthcare worker, a young lady, and you're worried about taking the vaccine because what's going to mean in you're becoming a mommy someday, it will have zero impact. If you get COVID, I can't guarantee that you'll survive COVID. People die from COVID. So that could affect your ability to become a mommy someday. And we have no idea what the long-term effects of COVID will be in people who get COVID in terms of how this will impact their pregnancy or fertility in the future. So the vaccine is your best bet to make sure that hopefully when it's the right time for you, you become a wonderful mommy. And if you receive the COVID-19 vaccine, you don't have to wait to become pregnant. So we sometimes will recommend when you take certain medications, don't get pregnant for a month, 2 months, 3 months, or X amount of time. If you get COVID vaccinated, you can get pregnant that night. There's no problem with getting pregnant after taking the COVID vaccine. So I hope that addresses the major concerns people have. I won't speak a lot more about the medical conditions or allergies that people have. Essentially, there is no medical condition other than people having serious anaphylaxis that would tell you do not get the vaccine. There may be individuals that have certain specific points in their medical history that has a question to be asked. Those should be asked to your doctor. And likewise, this official CDC position is even if you've had COVID-19 or if you have antibodies to COVID-19, you still should get vaccinated. And that's the official Mount Sinai health system position as well. Does the Delta variant change things around? Has it really made an impact on how we're doing in terms of COVID? And the answer to that is absolutely yes. So we certainly want to make sure that we don't get worse. We had 0 patients in the hospital for about a 10-minute period of time last summer. And we've gone recently, earlier in this year, we've had 1 or 2 patients in the hospital on a regular basis. But those that follow the regular medicine, daily medical huddle that we have, and those that are looking at our stats, you know that we are having roughly a census of about 20 patients every day, the majority of which are unvaccinated. And we only have had 1 patient recently in our ICU that's been vaccinated. And that was an elderly woman, an 80-year-old woman who had underlying comorbidities and had been vaccinated back in January or February. And therefore, that's what I'm going to talk about next in terms of who should we be giving a booster shot to, if anyone. And Delta has made this a discussion point. So Delta has changed things dramatically. Delta is much more contagious than the previous variants. And there is evidence now, a paper in the Lancet, that Delta is in fact more virulent. It is causing more infection than previous likelihood of getting an infection with the Alpha variant. And this Lancet paper from last week showed that comparing the Delta versus the Alpha variant, that more people got sick with the Delta variant. When you took a look at people that got infected, more people got sicker with the Delta variant. We don't know yet if that's 100% true. There aren't data really at this point to show, but also no data not to show that the Delta variant causes more death. But I think the general feeling of many people is that the Delta variant is a more serious virus in terms of the illness that it causes. We certainly are seeing more pediatric admissions in the United States, much more than previously. And we are seeing many more admissions in the younger age groups. The 30 to 39 age group has seen a dramatic increase in hospitalizations, all due to the Delta variant. In our hospital, almost all of the cases now are Delta. And across the country, it's well over 90% of the cases are Delta. So this virus has spread tremendously. In the last few minutes, I want to talk about the booster shots that you've all been hearing a lot about and what the data are to support giving them under what circumstances, if any. So we take booster shots for two reasons. One is to give us immunity the first time, and the other is to give you additional immunity after your immunity has waned. So there are two types of booster shots. They're called booster shots, but I really wouldn't refer to both of them as booster shots. The first one I would refer to is we probably didn't give the correct dosing of the vaccine by saying you only need to take 2 doses. But in severely immunocompromised people, moderately to severely immunocompromised people, about 50% of them did not produce adequate antibody after the initial 2 vaccines, or for the J&J 1 vaccine series. So therefore, the CDC now recommends that people that have that significant level of immunocompromise, for example, somebody who was a solid organ transplant recipient, that they should have received originally 3 doses. So they should get 3 doses now if they didn't get it originally. If you, let's say an immunocompromised person says, okay, now I'll get vaccinated. So they should get 3 doses, not 2. They should get it at time 0, and then 3 or 4 weeks later, depending on which vaccine you get, the Moderna or the Pfizer, and then they should get it at 28 days later after that. So basically, in your mind, you get it at time 0, at roughly 1 month, and at roughly 2 months. And that's probably the better way to give immunocompromised people COVID vaccination. About 50% of them don't respond to 2 doses, and about 50% of those that didn't respond to 2 doses will respond to a 3rd dose. And these are significantly immunocompromised people. And since we really don't have a great way of knowing how well these vaccines are going to protect in immunocompromised people, I recommend that all immunocompromised people, even if they've gotten 3 doses of the vaccine, should consider themselves in terms of precautions as if they were unvaccinated, meaning that they should always mask around other people when they're indoors. Now, I know that's a tough thing to ask people to do, but I think if you're significantly immunocompromised, that's a reasonable risk to take. And certainly in an indoor setting where you don't know the people there that they've been vaccinated. It's one thing if you're with your family and you know they've all been vaccinated and they're all healthy, not to mask when you're around them. But it's a big different thing. You're going into a mall, you're going into a public area indoors. If you're an immunocompromised person, even if you've gotten 3 doses of the vaccine, I would still recommend that you take precautions as if you were unvaccinated. Better to be safe than sorry. The other type of potential indication, not yet FDA authorized, is to take a booster shot because you had immunity, but it wanes over time. Clearly, in a laboratory setting, you can show that the numbers, the level of antibody goes down over time. This is true for people with COVID and have natural antibody. This is true with people who have vaccination and had antibody from the vaccination. And over time, if you measure it, it will go down. The big question, and this is true of many vaccines, they're levels of your numbers of, quote, immunity go down over time. But the big question is, does this mean anything? Does a level in a laboratory going down indicate that you're actually not immune? So if you look at the data that I presented earlier in the talk from New York City with Delta variant, the immunity did not seem to wane over time in terms of protecting you against serious illness. The immunity does seem to wane in time in terms of protecting you as fully as it did before from getting mild or even asymptomatic infection. And this remains the big question. How important, therefore, is it to give people a booster shot that may or may not be necessary for many people and that may or may not provide any real additional protection against significant illness? So we don't know at this present time whether booster doses are in fact necessary to provide this longer lasting protection, because it's really unclear at this point in time how long your vaccination protection from the 2 doses of the mRNA or the 1 dose of the J&J will last. So the Advisory Committee on Immunization Practices is looking at this very carefully, as is the CDC and many, many other individuals, including myself. And the best data that we have on this to date is the experience from Israel, where they had started giving 3rd doses in their elderly population initially, and now giving it to all of their population. And their data to date, which is not published, but is put out by the Israeli Ministry of Health, so it is, reliable in terms of the data, just the analysis of it is not done yet. Their experience shows that they had 0 long-term, complications from, and not long-term is the wrong word, they had 0 hospitalizations or serious illness in the younger people that had only 2 doses. And almost all of their serious complications, ICU, intubation, and death, occurred in their population that was starting to occur a little bit above 40, a little bit above 50, and then you started seeing some slight numbers of death in the above 60 and more in the 70 and 80, but still very low. And their experience with 2 versus 3 doses, they have seen a decrease in illness in people that got 3 vaccinations versus the people that got 2. But it remains unclear as to who that is really mostly beneficial for. In my analysis, and it's just my analysis, it's not yet any way approved officially, albeit the government has come out that they are going to recommend this in September, but that's only assuming the Advisory Committee on Immunization Practices approves this, and therefore the FDA then authorizes it. There will probably be, in my opinion, a recommendation that people above a certain age should get a 3rd dose to provide them longer lasting immunity for their, quote, waning immunity. Now, I don't know what age that will be. Based upon the experience in Israel, it would probably make sense to draw that line somewhere above the age of 50. Whether you do it at 50, whether you do it at 60, you do it at 65, it would be probably based upon that data in that ballpark. But that also would suggest that people younger than that at this point in time probably don't need a booster dose to provide longer lasting protection. That's my assessment today, September 1. There's an excellent chance it will change on September 2 or 3, because as we get more information, we need to update our recommendations. So therefore, I basically just said this slide. Clearly, all of the mRNA vaccines and the J&J vaccine, you can clearly show that by giving an additional dose, if somebody can please go on mute, I'd appreciate it. By giving an additional dose, either a 3rd dose of the mRNA or a 2nd dose of the J&J, clearly you boost the numbers that you can detect. So that's clear. The question is, what does that mean clinically? But the most important thing to remember from this talk is the urgency of vaccinating the unvaccinated. Because if you don't get exposed to somebody, then whether you got 2 doses or 3 doses, it makes no difference. You won't get COVID. And the more we vaccinate, the better we'll be against COVID. And almost all of the severe cases, as I pointed out earlier, are in the not yet vaccinated group. So please get vaccinated. And then one of my last slides, and then I'll take questions, is what about the co-administration of the COVID vaccines, any of them with other vaccines? I get a lot of questions now. I don't want to take the flu vaccine because I may have to take another booster shot of COVID. Well, how does that impact? So we originally had said, don't take the COVID vaccine within 14 days of getting a vaccine, either before or afterwards. But this was out of caution and not because of any data to suggest it was dangerous. And we have extensive experience giving other vaccines at the same time. We give the MMR all together. We try to add vaccines to only give one shot to little kids instead of giving them multiple shots. That's to help the kids, not to hurt the kids. So they don't have to get multiple shots and be traumatized. There is no reason to think that you cannot give together, with the data that we now have, the COVID vaccine with the flu vaccine. They can actually be given at the same time. We recommend give them in different arms. They're not in the same vial. So you give the COVID vaccine in your left arm, you give the flu vaccine in the right arm on the same day. Acceptable. This is the CDC website that I took this from. Simultaneous administration of COVID-19 vaccine and other vaccines such as flu on the same day is allowed. You can co-administer them within 14 days. Somebody says, oh, I just got the COVID vaccine last week. Can I get my flu shot today? The answer is yes. And I'll throw it a little plug. Don't hesitate to get your flu shot this year. It's important. We're entering into the flu season. It's September. So the flu vaccine is not yet available, but it will be available shortly. And I will get it as soon as I can because, as I do every year, I don't want to get flu. And flu shots, while nowhere near as good as the COVID vaccine to prevent the illness that the flu shot is supposed to prevent, influenza, it still is a good shot and highly recommended. And last year we had no flu because everybody was masking and distancing. This year, a lot of people are not masking and distancing. I would add my own aside. How come we're seeing cases of COVID in vaccinated people? One of the reasons is because they're not taking precautions. I'm vaccinated. I'm Superman. I don't need to take precautions anymore. So I think they're being exposed more than they would have been previously. In any event, last year we had no flu because everybody was very careful. This year people are not careful. We will see flu again this year. So please get your flu shot. So I'm always amazed that everybody's an expert on infectious diseases because they read something in the New York Times or they read something on social media. There's a lot of effort that goes into making these recommendations by all these extremely expert societies. And you have to, at some point in time, trust the experts. They have no hidden agenda. They're not being bought off by the drug companies. All the people sitting on the advisory committee for immunization practices get no reimbursement for that. They're not being paid off by the pharmaceutical industry. I've never gotten a check from the pharmaceutical industry for vaccinations in my entire career. So if somebody is getting these checks, please add my name to that list because I'm not one of those doctors that's being bought off. I'm giving you my own, quote, expert opinion. And that's who you should be listening to. So I thank you for listening. And I'm very happy to take any questions at this point in time. Thank you.
We do have several people that have submitted questions.
Okay, so why don't you read them? It might be easier for you to read them to me.
Certainly. We have two from Cheryl. Her first question is, how soon after having COVID would you recommend vaccination?
Okay, so my personal recommendation, which is not the same thing as the mandate, my personal recommendation is that a person who had natural COVID should, in fact, get vaccinated, but I would wait a minimum of 3 months, and I would probably suggest that there's no rush to do it until 6 months. Now, that's my personal recommendation. The CDC says that you have two choices. You can get vaccinated right away, or you can get vaccinated after 90 days. Everybody agrees that in the first 6 months after COVID natural illness, you're highly unlikely to get a second episode of COVID. So therefore, there's no rush to get vaccinated. However, because of the mandate from New York State, Mount Sinai health system is it's difficult to be in a situation where we start to track who got COVID when. So we're following the CDC recommendation, and I don't think it's dangerous. So I don't have any problems following that, in that after you're no longer contagious, which would mean usually after 10 days from the start of your COVID, it's okay to get vaccinated. So that would be the official system recommendation in terms of getting vaccinated, as long as you're more than 10 days after the start of your COVID, so you're no longer contagious, get yourself vaccinated to be in compliance with the New York State mandate.
Okay, her second question is, physiatrists are asking her how long should they wait after the vaccine to give joint injections? And if a patient receives a joint injection, do they need to delay the vaccine to 2 weeks after?
So the question really is in terms of taking any immunosuppressive therapy. So I would tell people that you don't want to take an immunosuppressive therapy right before you get vaccinated. And if you can push off people that take regular monthly injections, they should probably take their COVID vaccination at some midway point, so that they're at the nadir of the immunosuppression, but not taking the dose and then getting the immunosuppression the next day. So try to space it out if you have the luxury of being able to do so. For people that are, in fact, going to be on continuous, they're on daily steroids, so then just take the COVID vaccination. There's not much you can do about it. And the same thing would be an injection. I don't think it has any real significant immunosuppression, so I would take it.
Okay, we have one from Diana Gomez Hernandez. Should we do blood work to check if we have antibodies before taking a booster?
So the answer to that is absolutely no. There is no recommendation. The CDC actually says do not go and check antibodies. Now, if and when we do decide to give boosters, whether we'll change that recommendation and whether maybe in younger people that might be a reasonable thing to decide if we were to come out that all healthcare workers, for example, should get a booster shot, which is not part of the mandate. I want to stress that booster shots have nothing to do with this mandate. So then in the future, whether we come up with a good test that can measure neutralizing antibody, then that may be something to discuss. But right now, no. Because I see, by the way, that there are a bunch of questions on the chat. So maybe, Chaz, I'm just going to go through them myself and try to answer as many as I can. Pregnant women who receive the vaccination at the very beginning, should they get a booster shot during the last trimester? At this point in time, we have no evidence to say yes or no to that. So the official response would be no. Thoughts on ivermectin and hospitals being forced to give it. So that's something that we have unfortunately been through ourselves. So the official position of the NIH panel, the official position of the IDSA guidelines is that ivermectin should only be used in the setting of a study. There was a report from the FDA recently showing a significant increase in poisonings, cases being brought to their attention of people having significant complications from taking large doses of ivermectin. At the present time, there is simply no evidence. I would point out the largest study that was never published, it was only on the non-published med sites, was retracted as a falsification. And that was the study that everybody was quoting to say how great ivermectin is, and it was unfortunately made up. It was a horrible, horrible false study. And they, unfortunately, I have no idea why they did this, they made up data, and it's all falsified. Underlying conditions, diabetes boosters, we don't know at this point in time. Somebody who meets the criteria for moderate or severe immunosuppression, so possibly if you felt that a diabetic patient was in that classification, maybe. At this point, the boosters can be gotten at most pharmacies. The hospital's not yet giving it. We're focusing on vaccinating our first and second doses for our employees. But for those that are eligible to get a booster because of the immunocompromised situation, most pharmacies can give it. So is there any way we can know the variant for those patients who became COVID positive? So almost all of the variant cases, all the cases right now in the United States, it's well over 90% are COVID. And the most recent surveys that we've done here have been 100% COVID. Immunocompromised persons on medications like Humira need a third shot if they have antibodies after the first 2 shots. So that's one of the groups that would be potentially able to get a third dose because of the concern that they're immunocompromised. So those patients are eligible for a third dose. If you receive immunotherapy, can you get the vaccine? So I said, yes, it won't hurt you. But the question is, would it possibly not be as beneficial in that situation?
Glatt,
Yes.
I think you you just said COVID. I think you meant Delta, just to clarify that all of 100% of cases are Delta variant.
Yes. Thank you very much. I didn't realize I said that. Yes. Almost all cases across the country and in our region are all the Delta variant. We have not seen any of the other variants that are, quote, variants of concern, although they have been seen in rare cases across the country. But Delta is so contagious that it's really pushing everything else out of the way. Whether that will continue or not is unknown. Will pregnant women be allowed to delay the vaccinations as employees until postpartum? So the official recommendation is no. And whether that will be the final recommendation, that will remain to be seen. I think all of the healthcare systems are grappling with that issue. And that is a question that will be, I think all of the healthcare systems together are going to decide so that we don't have different policies between the different healthcare systems. Do you need to hold your medications to take the vaccine? So if it's possible to hold any immunosuppressive vaccines, it won't hurt your underlying disease management. So then I would suggest, if you could hold it, to go and hold those vaccines. If somebody is taking a certain medication and they could take it today or they could take it 2 weeks from now, so I would get the vaccination today and then take the immunosuppressive therapy 2 weeks from now. Again, we do not require people to wait 14 days from any immunizations any longer. That was an original recommendation, but if you got the shingles vaccine, that seems to be the most common one that I was asked about because it wasn't flu season. So if you got the shingles vaccine, you could actually get the COVID vaccination at the same time. What level of antibodies provide protection? So we really don't know the answer to that, which is why we don't recommend checking for antibodies. There are different types of antibodies. They're binding antibodies. They're neutralizing antibodies. There's no standardization of these assays. In a research laboratory, when they publish these papers, they're talking about very specific neutralizing antibody testing that's not generally available from Quest or LabCorp or commercial laboratories. And at the present time, therefore, we do not recommend routinely checking antibodies because I wouldn't know what to do with it. I would say the most common medical question I'm asked is people sending me their antibodies and say, what does this mean? And I tell them, I don't know. Ask the doctor that ordered it for you to explain it to you because I can't. And that's just the truth. AstraZeneca vaccine. So people with a history of thrombosis opt for Pfizer, Moderna instead of AstraZeneca. So I think that in the United States, if you're, AstraZeneca is not an option. So people that have got a single dose of AstraZeneca, so they should get a second dose of any of the other vaccines that are available. If they got 2 doses of the AstraZeneca, at the present time it's unclear should they get an additional dose. Do you recommend taking a third dose for adults under 30? So at the present time, I do not recommend. I would recommend against adults under 30 taking a third dose should it become even available to do so. I want to stress it is not included in the vaccine mandate has nothing to do with booster shots. I don't want to, I was hesitant to even speak about it. I don't want people to think they have anything to do with each other. One has nothing to do with the other. The vaccine mandate is for a first and second shot of the mRNA or for a single shot of the J&J. It's perfectly acceptable. Take a single shot of the J&J. So I absolutely recommend against people under 30 taking a booster shot at this point in time because there's no evidence, even from Israel, the Israeli experience doesn't recommend that that group is going to run into significant problems. What about mixing the vaccines? So the official recommendation is to take the same vaccine that you got for your first 2 doses. And if you need a third dose, to take the third one the same. There are no data to support that. No data to suggest that it would be beneficial to switch. For people that got a single dose of the J&J, there is no recommendation, even for the immunocompromised at this point in time, to take a second dose. So for the J&J at this point in time, J&J was only released, I think, back in March. So most people aren't at the point of 6 months from the J&J. And at this point in time, I do not recommend that people with the J&J take a second dose. If somebody's severely immunocompromised and they got the J&J, that's probably somebody that should have a conversation with their doctor about getting a additional dose, but there just is no information on it at this point in time. Live vaccines, in relation to the COVID vaccine, there's no evidence to suggest that they can't be given together. And I think I've answered most of the rest of the questions that I ran through on the chat. It's already 9:26. I don't like it when other speakers go longer. So I don't like it when I go longer as well. So I will thank all of you for listening. If anybody does have questions about this, any of the infectious disease physicians on staff would be happy to try to answer your questions for you. I'm always as available as I possibly can be to answer both your individual concerns or any concerns that you have regarding your patients. This is a really, really important subject. Please work as hard as you can to get any staff members that aren't vaccinated. Talk to them if you have any, if you're a colleague and you can influence them. That's really critical, to influence other people to get vaccinated. And certainly if you have patients that aren't vaccinated, it's just critically important to get vaccinated. This is how we'll save lives. I think by giving a vaccine talk like this, I may save more lives than I will in my entire career as an infectious disease physician. If we can get 100 people vaccinated from today's talk, that's 100 less people to get COVID. And when you're dealing with an older people mortality of 15, 20, 30%, we could save 10, 15, 20 lives by vaccinating those people. So please, everybody on this call, get everybody that you can possibly influence vaccinated. The vaccine hesitancy is going down. The FDA approval has made a difference. In some polls that I've already seen, we're at the lowest point in terms of numbers of vaccine hesitant for the COVID vaccine. But that still means there are people out there that are vaccine hesitant. And for any employee that has concerns still about getting vaccinated, I'll be happy to speak with you personally. So I thank you all very, very, very much for listening. It's always a pleasure to give these grand rounds. Next week, there is no grand rounds because of Rosh Hashanah, but we'll resume with our regular grand rounds on September 15th. We have an excellent talk planned by one of our new cardiologists, Dr. Sunny Goel, and he's a structural specialist, interventional cardiologist, and he'll be talking to us about some very important updates in cardiology. So look forward to seeing you then at that point in time, and everybody should have a wonderful, safe day. Thank you for listening.